Dear professors, dear colleagues, I would like to introduce MagnoVision, a device for electromagnetic neuromodulation and iontophoresis in the treatment of retinal and optic nerve diseases. My financial disclosure is as follows. MagnoVision is an MDR-CE certified neurostimulation device. Its efficacy and safety in the treatment of retinal and optic nerve diseases have been scientifically proven. MagnoVision consists of a headset and a processor. The headset contains 9 electromagnetic coils designed to stimulate the retina, optic nerve, and visual pathways. Each coil in the MagnoVision headset repeats at a frequency of 42 Hz, generating a magnetic field density of 2000 milligauss. Here is the design of the device. It has a headset and a microprocessor. There are 4 electromagnetic coils in the front part of the headset and 5 in the back. The application session is as follows. Once the headset is positioned correctly, its front and back parts expose the retina, optic nerve, and occipital cortex to a magnetic field of 2000 milligauss. This magnetic field is delivered in 42 pulses over 60 seconds, and each session lasts for 30 minutes. MagnoVision has 2 main mechanisms of action, 1, neuromodulation, and 2, iontophoresis. MagnoVision is a translational medicine product adapted from neuropsychiatry for use in ophthalmology. Transcranial magnetic stimulation, or TMS, uses electromagnetic induction to create an alternating electric current in a targeted region of the brain. It is a non-invasive neurostimulation technique that uses a repetitive and alternating magnetic field. The stimulator generates electrical pulses that are delivered to an electromagnetic coil placed on the scalp. The resulting magnetic field penetrates the skull and creates a secondary electric current in the underlying brain tissue, thereby regulating neural activity. The definitive FDA-approved indications for TMS are major depression, chronic neuropathic pain, obsessive-compulsive disorder, and post-stroke hemiplegia rehabilitation. For the year 2025, the International TMS Council has published a consensus for each indication regarding the coil application site, frequency, magnetic field intensity, session duration, and session frequency. For TMS to be effective, the coil's placement, the threshold magnetic field intensity, and the frequency are all important. To understand the mechanism of action of TMS, we need to discuss the concepts of action potentials and ion channels in neurons, threshold magnetic field intensity, optimum frequency, neuromodulation, and iontophoresis. In neurons, an action potential is the rapid and transient change in the electrical potential across a neuron cell membrane. It enables the transmission of nerve impulses. Sodium, potassium, calcium, and chloride ions move across the cell membrane through ion channels. The types of ion channels: ligand-gated, voltage-gated, and mechanically gated channels. The dominant ion channels in the retina are ligand-gated channels. The opening and closing of these channels are regulated by peptides that bind to specific receptors. In the optic nerve and visual pathways, the dominant ion channels are voltage-gated channels. The transmission of a neural impulse requires the movement of positively and negatively charged ions across the cell membrane. In the retina, the action potential is initiated by ligand-gated ion channels. Light focused on the retina from objects initiates the vision cycle. Opsin, rhodopsin, neurotrophins, and growth factors are secreted from the retinal pigment epithelium, triggering ligand-gated ion channels in photoreceptors. The resulting action potential, with its 42 Hz sinusoidal oscillations, stimulates the voltage-gated ion channels in the optic nerve and visual pathways with a domino-like effect. The neural impulse is thus transmitted to the occipital cortex. In the retina, 90 different peptides are synthesized to regulate ligand-gated channels. The action potential, which begins in the ligand-gated channels, is transmitted to the optic nerve and visual pathways through voltage-gated channels. For the occipital cortex to process the image with all its components, the action potential starting from the retina must be transmitted at a frequency of 42 Hz. If this value is slow, below 42 Hz, it is perceived as a decrease in image resolution, loss of contrast, blurred vision, and scotomas. If this value is transmitted rapidly above 42 Hz, it is perceived as neural noise, i.e. photopsia, flashes of light, and specks in the visual field. This 42 Hz oscillation is a critical value in the visual pathways. In the optic nerve and visual pathways, acetylcholine, noradrenaline, dopamine, and endorphins ensure that the transmission is optimized at the 42 Hz level. In genetic, ischemic, degenerative, inflammatory, and traumatic diseases of the retina, the levels of peptides that trigger ligand channels and initiate neurotransmission decrease. Photoreceptors enter a sleep mode called the dormant phase. If the dormant phase lasts too long, apoptosis and permanent vision loss develop. Photoreceptors in the dormant phase can be reactivated by the external administration of growth factors and external stimulation of voltage channels. Ischemic, inflammatory, toxic, and traumatic conditions in the optic nerve cause the nerve fibers in the on mode to switch to the off mode. Prolonged off mode leads to apoptosis and permanent vision loss. The external administration of acetylcholine, neurotrophins, growth factors, and erythropoietin, together with the external stimulation of voltage channels, can cause neurons in the off mode to return to the on mode. For external stimulation of ligand-gated ion channels, platelet-rich plasma, Wharton's jelly-derived mesenchymal stem cells, exosome injections, and erythropoietin are used as growth factor sources. For external stimulation of voltage-gated ion channels, repetitive electromagnetic stimulation, direct electrical stimulation, and photobiomodulation are used. When it comes to the external stimulation of voltage-gated ion channels, MagnoVision offers several advantages over other methods. Unlike direct electrical stimulants, there are no electrodes that make contact with the cornea. Its simultaneous iontophoresis feature, when applied along with growth factor sources, stimulates both ligand-gated and voltage-gated channels together. And since there are no consumables, the sessions are quite economical. Studies on the occipital cortical prosthesis, which is being researched for the treatment of total blindness, have clearly mapped which regions of the brain and visual pathways produce phosphines upon external stimulation with RTMS. The threshold magnetic field intensity and frequency have also been clearly identified. MagnoVision's design, coil placement, the magnetic field intensity it generates, and its 42 Hz frequency were all designed based on this fundamental information, and its efficacy and safety have been confirmed through clinical research. Neural impulses that fail to form because ligand-gated channels cannot be stimulated by peptides can be generated by externally triggering the voltage-gated channels with MagnoVision. Stimulating the voltage-gated channels externally with MagnoVision 42 times in 60 seconds allows the impulses reaching the occipital cortex to be processed, reactivates dormant photoreceptors, and enables optic nerve fibers in the off mode to switch to the on mode. Another important feature of MagnoVision is iontophoresis. This is the process of delivering drugs across the membrane by using a voltage gradient. Molecular mobility is increased through electrophoresis and electroosmosis. The electromagnetic field increases membrane permeability. The applied alternating electric current accelerates the active transport of the substance. Biological molecules with a peptide structure, such as growth factors, regulate biological reactions within the cell by binding to specific receptors on neurons. The binding of peptides to these receptors leads to endocytosis at the cell membrane. If there are more bioactive molecules than receptors, the endocytosis process requires refractory periods. The external stimulation of voltage-gated channels accelerates the endocytosis process, which increases the amount of peptide entering the cell and speeds up the cellular metabolic response. The natural barriers for drug molecules to reach the target tissue are scleral pores in subtenon injections, tight junctions in the choroid and RPE, which form the blood-retina barrier, and the internal limiting membrane, or ILM, in intravitreal injections. Molecules with a molecular weight of less than 50 kilodaltons can pass through scleral pores and natural membranes via passive diffusion. Molecules larger than 50 kilodaltons can pass through natural membranes by having their electrical charges altered and their vibrations increased. MagnoVision vibrates the positive charges of drug molecules away from the coils at a frequency of 42 Hz. This vibration and speed of movement increases the concentration of the drug molecules in the target tissue. Due to the repulsion between the positively charged ions and the coil, the vibration and mobility of the drug molecules are increased. I will now demonstrate, using case studies, the 7 indications for which MagnoVision has proven both effective and safe. MagnoVision is highly effective in treating retinal and vitreous hemorrhages. A 67-year-old woman presented with sudden vision loss in her left eye for 3 days. She had been followed at another center for 2 years with a diagnosis of polypoidal choroidal vasculopathy, or PCV. There she received 8 intravitreal anti-VEGF injections in her left eye, the last one a month ago. For the past week, her hypertension has been irregular, and she came in with a sudden loss of vision following a severe headache. We see an extensive submacular hemorrhage in the patient. The classic treatment recommends pars plana vitrectomy, subretinal tissue plasminogen activator, and gas. However, the treatment complications and outcomes are debatable. So what did we do? To increase the phagocytosis rate of the pigment epithelium pump, we used platelet-rich plasma PRP, which contains epithelial growth factor, citrate as an anticoagulant to liquefy the coagulum resin, anti-VEGF bevacizumab to prevent new hemorrhages, and a combination of electromagnetic iontophoresis MagnoVision to induce vibration of the iron atoms in the erythrocytes. We mixed 1 milliliter of PRP with 0.5 milliliters of Altuzan and injected it subtenon as a single dose. Immediately afterward, we started MagnoVision iontophoresis. We repeated this procedure for 10 days. On the 5th day, we see that the hemorrhage has significantly shifted and reduced considerably. By the 10th session, the hemorrhage had completely resolved. Our patient's vision improved from hand motion to 1/10. It is debatable whether this result could have been achieved with classic treatment. Another indication is pre-retinal hemorrhages. This is a case of Valsalva retinopathy, a sub-ILM hemorrhage that developed after coughing fits. The classic treatment recommends YAG laser drainage and/or pars plana vitrectomy. What did we do? We mixed 1 milliliter of subtenon PRP with 0.5 milliliters of Altuzan. Immediately afterward, we applied MagnoVision iontophoresis for 10 days. On the first day, the hemorrhage drained into the vitreous. By the 10th day, the vitreous hemorrhage had cleared significantly. Our patient's vision improved from hand motion to 7/10. Another case is a submacular hemorrhage. A 19-year-old girl. Her brother threw a television remote, and she presented with a sudden decrease in vision. There is a significant hemorrhage under the macula. The classic treatment recommends pars plana vitrectomy, subretinal tissue plasminogen activator, and gas. Now, if this were our own daughter, would we perform this surgery? It's such a traumatic surgery. We'd have to go under the retina. The results are debatable, questionable, and the complication rate is high. What did we do? Because it's non-invasive, we injected a mixture of subtenon PRP with 0.5 milliliters of Altuzan at 5-day intervals. We also applied MagnoVision for 10 days. We saw the hemorrhage disappear rapidly with each session. In the final session, a very small minor ellipsoid zone defect formed. However, at the 1-year follow-up, we saw that the defect had also significantly improved, and we were able to improve the patient's vision from 1/10 to full vision non-invasively. Another indication where MagnoVision is effective is chronic central serous chorioretinopathy. We have a large case series on this as well. A 49-year-old male describes recurrent sudden vision loss, contrast loss, and macropsia in his left eye for 2 years. The attacks occur every 2 to 3 months, and he describes a decrease in vision after each attack. In classic treatment, photodynamic therapy is recommended to reduce choroidal pressure or micropulse laser to stimulate the pigment epithelium pump. So what did we do? To increase the retinal pigment epithelium pump function and the rate of reepithelialization, we used PRP, which contains epithelial growth factor, anti-VEGF to tighten the choroidal pores, and we used MagnoVision to help the growth factors and anti-VEGF molecules injected into the subtenon space to pass into the choroidal matrix and subretinal space. We administered 3 doses of a PRP Altuzan mixture to the patient, 1 every 3 weeks, and after each application, we performed MagnoVision iontophoresis. At each follow-up, we observed that the fluid decreased, the pigment epithelium became more regular, and the ellipsoid zone settled after the final application. Our patient's vision improved from 3/10 to 9/10. Our next case is a 43-year-old male. He has had recurrent sudden vision loss and contrast loss in his left eye for 3 years. He describes attacks every 4 to 5 months. When the patient first came to us, we saw that the ellipsoid zone, the pigment density had decreased, meaning the photoreceptors had entered a dormant phase. However, since there was no fluid at this stage, we did not intervene. 6 months later, he came to us with fluid. Here we applied 3 sessions of a subtenon PRP Altuzan mixture, 1 every 3 weeks. Immediately afterward, we performed MagnoVision iontophoresis. In the final session, the fluid had completely disappeared, and the pigment density of the ellipsoid zone had increased compared to its initial state, which showed us that the photoreceptors had been reactivated. Our patient's vision improved from 3/10 to 8/10. Another case is a 45-year-old male. Similarly, he has had attacks for 3 years. We administered 3 doses, one every 3 weeks, of 1 milliliter of PRP containing 0.5 milliliters of Altuzan, injected subtenon. Then we applied MagnoVision iontophoresis. We saw a significant decrease in fluid, and in the final session, photoreceptors settled and pigment epithelium regularized. Our patient's vision improved from 4/10 to full vision. Another important indication for MagnoVision is optic neuropathies. A 66-year-old male patient presented with decreased and blurred vision in his right eye following a hypertensive crisis. The patient is a heavy smoker. Visual acuity was 2/10. He can use 42% of his visual field. Here, there's a value called the fundus perimetry deviation index. This shows us how much of the visual field the patient is using. We can see that the optic nerve is edematous. After neurological and cardiological examinations, we confirmed it was anterior ischemic optic neuropathy. We made sure there was no intracranial or orbital mass. In classic treatment, pulse steroids are recommended. The purpose of pulse steroids is to quickly resolve the edema of swollen axons within the optic nerve sheath, thereby restoring perfusion. However, when we give pulse steroids to these patients, the underlying hypertension often becomes more uncontrolled. If there's underlying diabetes, that also becomes more unregulated. After pulse steroids, we observe that the harm outweighs the benefit. And unfortunately, the results are not very good in ischemic optic neuropathies. So what did we do? We used oral idebenone to resolve the edema 3 times a day. Idebenone is a mitophagy agent. It reduces edema by triggering autophagy and increases ATP production. This time into the PRP, we used erythropoietin, 0.4 milliliters of erythropoietin. Erythropoietin increases both reperfusion and capillary perfusion. We performed our subtenon injections on the first day, the first week, and the second week. Immediately afterward, we applied iontophoresis with MagnoVision, and for neuromodulation, we applied MagnoVision for 10 days. 2 weeks later, our patient's vision was 7/10. The visual field was 88%, and the papilledema had resolved. We can see it here. Our patient was able to use 88% of his visual field from the first application to the final session. His vision improved from 2/10 to 8/10. Unfortunately, we cannot achieve this with steroids or classic treatments. Our next patient is an academic, a professor. He presented with a complaint of decreased vision following COVID pneumonia. His visual acuity was 4/10, and he can use 56% of his visual field. The pathophysiology is that COVID antibodies cause endotheliitis and microthrombi. Both ischemia and inflammation lead to optic neuropathy. In classic treatment, plasmapheresis is recommended to clear the autoantibodies, and pulse steroids are also recommended. So what did we do? We started the patient on oral citicoline. It's an acetylcholine precursor to accelerate neurotransmission and for cell membrane repair. Again, in the same way, we injected a mixture of PRP, 1 milliliter, and 0.4 milliliters of erythropoietin subtenon. We performed our injections on the first day, the first week, and the second week. We also applied MagnoVision for 10 sessions. In the final session, his visual acuity was 9/10, and he was able to use 74% of his visual field. Our patient is overall very satisfied, yes. Another optic neuropathy is toxic optic neuropathies. We can get very significant results in cases of methyl alcohol intoxication. If we can catch the patient within 1 month, after sessions of Wharton's jelly-derived mesenchymal stem cells and MagnoVision, they can go from this state to this state if we catch them within a month. If we catch them within 3 months, we can still save them, albeit with mild scotomas. However, these patients usually come to us very late, after a period in intensive care and a long rehabilitation process. Unfortunately, after 3 months, we can't get very good results. Significant apoptosis has already occurred. But if we can catch methyl alcohol intoxications early, we can very significantly switch the receptors from off mode to on mode. Another important indication for MagnoVision is retinal capillary ischemia. A 27-year-old male patient. He is a friend of ours, an emergency medicine specialist. He underwent nasal septum deviation surgery. During the operation, they injected adrenaline into his nasal mucosa due to mucosal bleeding. The patient experienced a decrease in vision following severe systemic vasoconstriction. Here we see that capillary perfusion is severely impaired. We see edema in the outer plexiform layer and that the ellipsoid zone has become irregular. This has a similar logic to ischemic optic neuropathy. In classic treatment, nothing is recommended other than systemic and topical steroids. So what did we do for the patient? We injected a mixture of PRP, 1 milliliter, and 0.4 milliliters of erythropoietin subtenon. Immediately afterward, we applied MagnoVision iontophoresis. Our patient received 3 sessions of treatment, one every 3 weeks. After the treatment, we saw that capillary perfusion had significantly increased, the edema in the outer plexiform layer had resolved without any atrophy, and the ellipsoid zone was significantly reactivated. Our patient's vision improved from 1/10 to 10/10. Our next patient is a 67-year-old woman. Her vision is 1/10, and she describes a progressive decrease in vision. She has had type 2 diabetes for 30 years. Now, if we consider this as a classic diabetic macular edema, intravitreal Ozurdex or anti-VEGF injections are recommended. However, there are no signs of inflammation here. We don't see any white dots, we don't see any exudation. The cause of the edema here is capillary ischemia. If we were to give this patient Ozurdex or anti-VEGF, we would increase the ischemia and worsen the patient's vision. So what did we do? We injected 3 doses of PRP and erythropoietin subtenon, one every 3 weeks. Afterward, we applied MagnoVision iontophoresis. With each visit, we saw that perfusion increased, the ellipsoid zone became more regular, and the edema resolved. Our patient's vision improved from 1/10 to 4/10. Another indication is age-related macular degeneration. A 67-year-old woman with decreased and distorted vision in her right eye. In classic treatment, intravitreal anti-VEGFs are recommended, and that's what we did. We administered 3 doses of Eylea 1 month apart. However, with each visit, we saw that the CNV had worsened. There was no response to Eylea. While we were considering changing the medication, we administered the 4th injection as Eylea again. Immediately afterward, we applied MagnoVision. Right after applying MagnoVision, we saw that the CNV regressed very rapidly. In cases resistant or unresponsive to intravitreal anti-VEGF, applying MagnoVision immediately after the intravitreal anti-VEGF injection increases the subretinal drug concentration through the effect of iontophoresis. We have a rabbit study on this. In cases where we applied MagnoVision after intravitreal bevacizumab, the subretinal drug level was 10 times higher than in the group where we didn't apply it. We are about to publish this. In our clinical practice, routinely applying MagnoVision after intravitreal anti-VEGF provides an increase in treatment response and a significant reduction in recurrences. Our next case is non-exudative or dry type macular degeneration. A 77-year-old woman followed for 12 years for macular degeneration. No anti-VEGF injections were given. Left eye, hand motion vision at 1 meter from geographic atrophy. Right eye, 2/10 vision with a small central ellipsoid zone in the atrophic area. What is recommended to the patient to preserve this? Traditionally, the AREDS formulation is suggested, telling the patient to take their vitamins. Currently, complement inhibitors are being discussed. What did we do for the patient? At 1-month intervals, we administered 3 doses of PRP, each containing 0.4 milliliters of erythropoietin and MagnoVision. The patient's vision improved from 0.2 to 0.4. We monitor the patient with follow-ups every 4 to 6 months. Their vision is still good. Capillary perfusion has increased. And in the pattern ERG, we saw that the amplitude and frequency of ganglion and retinal functions improved significantly. Our patient is satisfied. Our next case is a drusenoid pigment epithelial detachment. The classic treatment is intravitreal Vabysmo. The results are not bad either. However, considering that a retinal pigment epithelium causing such drusen accumulation is severely dysfunctional and dormant, we administered Wharton's jelly-derived mesenchymal stem cells to the patient. These mesenchymal stem cells are a source of allogenic growth factors and neurotrophins. After the stem cell injection, we applied a total of 10 sessions of MagnoVision to the patient, 1 session per day. Afterward, 1 session of MagnoVision was applied every 4 months. MagnoVision increases the exosome degranulation of stem cell. Exosomes contain growth factors and neurotrophins. Through electromagnetic iontophoresis, growth factors and neurotrophins are required to be transported from the scleral pores to the choroidal matrix and then to the subretinal space via tyrosine kinase receptors. Now, if we only use stem cells, their effect is limited. After 3 months, the stem cells also stop releasing exosomes. For this reason, it's necessary to apply MagnoVision at certain intervals to stimulate the stem cells. After the stem cell and MagnoVision applications, we see that our patient's drusenoid PED has liquefied, and 1 year later, we saw that the ellipsoid zone was reactivated without any atrophy. Another important indication for MagnoVision is retinitis pigmentosa. We also have a large number of patients with long-term follow-up for this condition. Now, a 42-year-old woman with night blindness starting at age 10, progressive constriction of the visual field, and she describes prolonged dark adaptation. She says her vision gets worse every year. Now, in classic treatment, some of our colleagues say there is no cure. Now, it's like this. When listing the complications of retinitis pigmentosa, macular edema, cataracts, and epiretinal membranes are mentioned. The fourth complication is death. These patients are prone to suicide. They are patients with high anxiety. When a colleague tells them there's no cure, in a study conducted in South Korea, 1 out of 8 patients commit suicide. We should definitely not tell these patients there is no cure. So what did we do for this patient? A total of 3 sessions of autologous PRP, erythropoietin, and MagnoVision loading 1 month apart, followed by a booster dose repeated every 4 to 6 months. After 3 loading doses, an increase in the pigment thickness of the ellipsoid zone was observed on OCT. Here we see the pigment density in the ellipsoid zone in its initial state, and then its final state after the 3rd loading dose. This shows us that the photoreceptors have been reactivated. Our patient also subjectively states that her vision is better, her contrast has increased, and her visual field has expanded. Another type of retinitis pigmentosa is one that presents with such intense edema. If steroids are used for this edema, no response is obtained, because the cause of the edema here is not vascular leakage, but the accumulation of mutant proteins. Large chain amino acid proteins are formed from the retinal pigment epithelium, and they accumulate. This edema occurs due to oncotic pressure. We cannot resolve this edema with steroids. Secondarily, this patient also developed vitritis and cataracts. If we perform PRP on this patient, we increase mutant protein synthesis. We make the patient worse. The patient's complaints increase even more. Inflammation, edema, and cataracts accelerate further. PRP should absolutely not be performed in these cases. It is contraindicated. These patients require direct stem cell application. Wharton's jelly-derived mesenchymal stem cells secrete allogeneic growth factors, neurotrophins, and anti-inflammatory cytokines. The application of Wharton's jelly-derived stem cells and MagnoVision triggers autophagy and accelerates the digestion of mutant proteins. As a result, we see that the patient's edema has significantly regressed, the vitritis and signs of inflammation have disappeared, the pigment density in the ellipsoid zone has increased, and the photoreceptors have been reactivated. Our final indication is glaucoma, a 48-year-old male patient who, 4 months ago, presented with severe pain, blurred vision in his right eye, and vomiting, was diagnosed with acute angle closure glaucoma at an external center and underwent medical treatment and laser iridotomy. He has been using Tomec for 4 months. For 4 months, the patient has been describing scotomas and a narrowing of the visual field in his right eye. In terms of classic treatment, everything that could be done has been done for the patient. The patient can use 60% of his visual field. He has a scotoma like this. What did we do for the patient? We administered subtenons injections of autologous PRP and erythropoietin at 3-week intervals. Immediately after, we applied MagnoVision. We observed an increase in the anatomical thickness in the retinal nerve fiber analysis and the ganglion cell complex. In the pattern ERG, we observed that the amplitudes and frequency improved significantly with each visit. In the final session, our patient was able to use 77% of his visual field. His visual acuity improved from 3/10 to 7/10. The patient also subjectively stated that his vision was much better. Transcranial magnetic stimulation has very strong scientific evidence in neuromodulation and neuropsychiatry. It has been in use since 1985. If we consider that the retina and optic nerve are specialized parts of the brain, these scientific proofs can also be considered valid for ophthalmology. However, you can access the full text of our publications and treatment protocols on ophthalmology by visiting our website. Thank you for your attention.